In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, review a recent survey about OAS-CAHPS, discuss credentialing applications. We follow up on an earlier discussion of RN Administered Conscious Sedation, and we discuss our preparations for ASCA 2025 in Denver this week. In our focus segment, we discuss incident reporting.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 242 of the ASC Podcast with John Goehle, recorded on April 29th, 2025 from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by their relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So we're quickly recording this episode. It'll be somewhat shorter, I think, this week. As we prepare for ASCA 2025, I'll be heading out tomorrow morning. We're recording on Monday. And I'll be heading down on Tuesday to get our booth ready. And yes, we have a booth, Sue, for the first time ever.
ASCA, yep.
Yeah, Ambulatory Healthcare Strategies has booth number 1324. That's 1324. So make sure you stop by and mention that you listen to our podcast and get some goodies. And more information about Ambulatory Healthcare Strategies, more information about ASC-Central, and of course you already know about the podcast if you're listening to us. Yes. So, but we'd love to talk to everybody that attends and love to have feedback. And if you are going to be there and would like to be on the podcast, if you send an email to info@ascpodcast.com. Now, of course, this recording will go on well after the conference is over, so don't send it to me after the conference is over. But if you send us an email while we are heading toward Denver or while we're in Denver, I will add you to our mailing list. And what we'll do is we'll give you information about when and where we'll be recording some of the special episodes. We usually record about 2 or 3 special episodes, and depending upon the number of people that are going to be there, we'll try to find a relatively big room. We've actually been able to get some pretty big rooms in the past, conference room or presentation room, and record from there. But we're very excited about this conference, and we're very excited about having a booth for the first time. I'll be doing a presentation on financial management 101, and Lori's going to be doing one on infection control, kind of an update for infection control coordinators. And of course, there's always a lot of great conference sessions during the conference. So, and a great, we always have a lot of fun on Friday night, which is when we have the big party. And I've been, Stu, I think this is going to be my, 35th year doing this with only 1 year off. which of course was during the pandemic. I have not missed a conference that ASCA and its predecessor FAST has put on in ever since I started in the industry in 1990. So it's a record that's, I think, hard to break. I'd be interested to know if anybody else has been going for as long as I have. So again, it's in Denver, Colorado, and as I said, send us an email at info@ascpodcast.com. Even if you just want to say that you're there, and we'd love to hear more from you as to any suggestions that you might have for the podcast. And again, you feel free to go to our booth, 1324. We have some recent news. ASCA, the ASC Association, did a survey recently. They call this ASCA's 60-second survey, which is a very quick survey that they send out to members. They did the survey in March 2025 and received 261 responses from surgery centers in 44 states. And now we've talked quite a bit about OAS-CAHPS over the last, 6 months at least. And this is kind of interesting just to kind of see 3 months into the implementation of OAS-CAHPS and the requirement for OAS-CAHPS for surgery centers, what the responses have been. And again, I'm going to give a link to the ASC Focus website so you can read the actual article. But what ASCA indicated based upon the survey is that facilities are, as we know, facilities are required to contract with a vendor approved by CMS to administer the CAHPS survey. All the facilities administering this survey in March of 2025, 61% are using Press Ganey as their CMS-approved survey vendor. They were by far the most popular vendor out there. The next most common vendors reported were J.L. Morgan at 13%, Arbor Associates at 9%, and Nexus Health Resources at 5%. In all, survey respondents named 12 different companies that are administering the survey. Only 10 facilities reported not administering the OAS-CAHPS survey, with the most common reason being their low Medicare volume. Now, keep in mind, ASCs with fewer than 240 Medicare fee-for-service claims per year are not required to participate in the ASC program at all, including OAS-CAHPS. Now, so we find that many of our clients over at Ambulatory Healthcare Strategies haven't been terribly happy with their interactions with some of these vendors out here. And that kind of comes out in vendor satisfaction score. So according to the 60-second survey from ASCA, the vendor satisfaction was 6.9 out of 10. So I wouldn't think that that's a very good score.
It's not great. It's not awful.
It's not awful, right,
I think a lot of the places just ended up, they really didn't know exactly what to expect. And I think there are places that had to stop accepting people. And, they just were overwhelmed.
Yeah. I think
it's not good, though.
Yeah, it's not good. But I think, of course, a lot of it is this learning. I mean, that's a lot of facilities to bring on very suddenly. And, as much as we were trying to get everybody to, move a little bit quicker during 2024, of course, a lot of people waited to the last minute to do it. Now, ASCA also pointed out the OAS-CAHPS survey has 5 approved survey administration modes: electronic with mail follow-up, electronic with phone follow-up, phone only, mail only, and mail with phone follow-up. So according to ASCA, in the March 2025 survey, 52% of the facilities reported using the electronic with mail follow-up survey method. The next most common methods were electronic with phone follow-up at 21% and phone only at 10%. When all facilities were asked whether they would consider moving to an internet-only or text-only based survey mode, 72% responded that they would be interested. So that would be interesting to see whether, the population or patient population are ready to move to internet or text-based system. So I thought this was very interesting information. And again, I know we've said this over and over again, but if you have not implemented OAS-CAHPS and you're doing over 240 Medicare fee-for-service cases per year, you need to implement this program. Otherwise, you're going to be subject to the 2% reduction in your increase in 2026.
Do they have any idea yet on what kind of response rate they're getting on these long surveys?
Yeah, that's an interesting question. And it's a question I want to ask Kara Newberry when I see her at ASCA 2025 in Denver this week, because she has been really up to date. I haven't talked to her since Washington's state association meeting. So that's a really good question to ask, and maybe we'll get some feedback from her.
Yeah.
I want to talk about some recent experiences. I recently did a mock survey for a organization that didn't do an application for privileges because they argued that the doctors and the anesthesiologists were all contracted. I have to admit, I didn't understand the logic. I pointed to the accreditation organization's standards and said it's very clear that every provider has to go through a credentialing and privileging process, which would include an application. So the biggest problem I see with not having an application really falls back on the accreditation standards for all of the accreditation organizations, which indicate that that the application has to include a formal statement releasing the organization from any liability in connection with the credentialing decisions. The application includes the applicant's attestation to the accuracy and completeness of the application and any additional information that's provided. And, of course, that the application has got the applicant's stated signature indicating that they have when they sent their application in order to be able to prove that application came in before the privileges were granted.
I think people get confused between like employee and credentialed provider, and then they're kind of like, well, they're just contracted. They're not really, we don't have responsibility for them, but of course you do if they're touching your patients. Yeah,
so again, this organization, is going to have some problems with their survey if they don't, fix this problem. So I think, again, I haven't seen this a lot in the past, but I think people don't always take the credentialing and privileging process seriously. If you want more information about how to do credentialing and privileging, we do have a conference we did in early 2024. And you can get access to an on-demand version of that conference at ASC-Central.com. Let's talk also about conscious sedation. We talked about this a bit in episode 239, but there continues to be a lot of discussion and questions lately about RN Administered Conscious Sedation. This is when there is no anesthesia professional in attendance to administer sedation to a patient. And, of course, this is generally being driven by the anesthesia crisis. Centers are looking for alternatives for providing anesthesia. Now, a couple things to remember. Sue, and you and I have talked about this quite a bit, and many of our nurses on our staff over at Ambulatory Healthcare Strategies, many nurses just don't want to do this. I mean, you can talk about it yourself. How comfortable would you? I mean, you're a nurse, you're a pediatric nurse, not exactly, somebody that is, you're used to dealing with critical patients, but even you have said that you wouldn't want to do this.
No, and I've, obviously had training in PALS and then pairs and other, I feel like it's not really our role. Unless if you have somebody who really wants to and you're really willing to provide them with the good education
and
resources, they're comfortable and you're doing it enough that they can remain comfortable and stay in practice for any kind of odd things that might come up. You have to get that instinct for it, I think. Yeah. And you can't, if you're only doing it once in a while, you may technically know what to do. But I don't know. It's a tricky thing. I think there are people that would be willing to do it. I don't think people should be pushed into it, though. If they're not comfortable, it's not a safe situation.
Yeah, that's a very good point. And I think your comment also about doing it enough to be competent at it. This isn't something you do like, maybe, once every couple months. You really need to be doing it regularly in order to make sure your skills are up to par. And, of course, if you are going to do this, and many doctors right now are looking into this as a solution, and I've been seeing situations in which the doctors are really pushing the nurses to do this, and they're getting pushback from the nurses. And I got to say, I have to defend the nurses in this one. If you are not comfortable, you really have to stand up and tell the doctor, this isn't something you're comfortable doing. And it puts a lot more risk on the nursing staff and the physicians. You have to remember that without an anesthesia provider, you have a considerably diminished capability to respond to emergency situations. I think we can all agree that anesthesiologists and CRNAs have a lot more training in how to rescue a patient. And when something happens, it's going to fall upon the nursing staff and it's going to fall upon the physician who's supervising that nurse. Now, you have to make sure that RNs have demonstrated training on how to do RN Administered Conscious Sedation. And there's various certification programs out there. And I use that term certification loosely. Basically, educational programs that you go through. You take a test at the end and you get a certificate that indicates that you went through the training. You also have to remember that both the physician and the RN has to have ACLS certification. You're going to have approval of privileges for the nurses to do this conscious sedation.
And make sure, of course, that you always do the annual competencies to make sure they're keeping up on their skills.
Right, and make sure the person doing the competency is indeed competent to be able to do the competency.
Yeah.
Well, that didn't sound quite right, but I think you know what I mean. And I really recommend that if you have an anesthesiologist available on your staff, even if they just come in, once a year in order to do these competencies, that anesthesiologist be in charge of doing the competency. Make sure everyone participates in the code blue drills, particularly the nurse and the physician who's going to be doing the RN Administered Conscious Sedation. I think this is kind of obvious, but I've seen many cases where the code blue drills do not include the physicians, and that's just not right.
Yeah, and this is really important. You also need to make sure that the registered nurse in the room is not the circulator, and that their only function in the room is administering the sedation and monitoring the patient. They have to focus completely on that patient.
That's right. So there is going to be higher staff, and I think that stands to reason if you're going to be doing RN Administered Conscious Sedation, because the sedation is indeed going to be, instead of administered by an anesthesiologist or a CRNA, it's going to be administered by the RN, whose only duty is this. And lastly, just make sure that the physician has been granted specific privileges to supervise the nurse that's administering the sedation. So, Sue, incident reporting is always an issue, and it's often cited as an area for opportunities for improvement in surgery centers during surveys. So we thought we would dive into it a bit more today in our focus segment. So let's take a short break, and when we come back, we're going to talk about incident reporting. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. Welcome to our focus segment on incident reporting. We'll be talking about incident reports, what to include in the reports, who should write them, how to investigate those incidents, how to identify opportunities for improvement, and how to report outcomes to the Quality Assessment and Performance Improvement Committee and the governing body. This process is absolutely essential for patient safety, for regulatory compliance, and, of course, for continuous quality improvement. And it is governed by the CMS conditions for coverage and the accreditation standards for, all the major accreditation organizations. So why did I select this topic today? Well, so during some recent survey experiences, I've seen quite a bit of disparity in people's response to incident reports and how they document them. Some doing an incredible job, and some that, barely do anything at all with the incident reports. So I thought that it's kind of important for us to revisit this topic. And what we have to remember, this isn't just about documenting what happened with the particular incident that you're putting on paper, but what you can learn from it. How can you avoid a recurrence of this? That's the whole concept of quality improvement, and its basis really is in incident reporting. I've said this many times before. A good quality improvement program starts with good incident reporting. No incident reporting at all means that you probably don't even really have a quality improvement program, and certainly don't have a robust one.
And that kind of goes with everything. Every time we talk about risk assessments, we talk about incident reports, all of these things that you do having to do with QAPI, you're gathering the data and then you're doing something with it. And you're trying to improve, you're trying to make sure the unexpected doesn't happen, or whatever did happen doesn't happen again.
We want to learn from our mistakes, or we want to learn from those things that didn't quite work out the way we wanted them. So here's some key points. Incident reports document the unexpected events, including adverse events that may impact patient safety or quality of care. And the CMS conditions for coverage and accreditation standards set very clear expectations for incident reporting and follow-up. And effective incident management strengthens those quality improvement programs and ensures governing body oversight, which are, again, all requirements of both the conditions for coverage under the Medicare regulations and the accreditation standards. So let's start by talking about actually preparing an incident report.
So according to CMS Conditions for Coverage, Section 416.43, ASCs must maintain an ongoing data-driven QAPI program that identifies and addresses incidents, including adverse events.
So what's important here is that you refer to your accreditation organization. Each of the accreditation organization has different standards related to these incident reports. I'm going to go over two of them in a few minutes here. So let's give some examples of the standards related to adverse events, incidents, and sentinel events from the Joint Commission and AAHC in particular. So we'll start with the Joint Commission. So the Joint Commission defines an incident as any unexpected event that disrupts normal operations, affects patient care, or has the potential to cause harm, but does not necessarily result in serious injury or death. In ASCs, incidents include near misses, minor injuries, medication errors, equipment malfunctions, or process failures that could impact patient safety or care quality. At a higher level, a sentinel event is an unexpected occurrence involving death, serious physical or psychological injury, or the risk thereof. Serious injuries include events such as loss of limb or function. And in ASCs, examples include wrong site surgery, severe allergic reactions leading to hospitalization, or unanticipated patient deaths or other events. Moving on to AAHC. AAHC's definition of incidents are any clinical or non-clinical occurrence that's not consistent with the routine care or operation of the organization. Incidents may involve patients, visitors, employees, and medical or dental staff members. And they go on to define an adverse event as any injury or harm to a patient resulting from the delivery of medical care or services. AAHC expects an organization's definition of an adverse event to include an unexpected occurrence during a healthcare encounter involving patient death or serious physical or psychological injury or illness, including loss of limb or function, not related to the natural course of the patient's illness or underlying condition, or any process variation for which a recurrence carries a significant chance of serious adverse outcome, or events such as actual breaches in medical care, administrative procedures, or other events resulting in an outcome that is not associated with the standard of care, acceptable risk associated with the provision of care and service for a patient, and events involving reactions to drugs or materials. So I think, Sue, the big takeaway from both of those accreditation organizations and both the definition of incidents and adverse events or sentinel events, if it's Joint Commission, is that we have to remember it's not just incidents or it's not just issues that involve patient care. It's also things that, such as equipment malfunctions. Yeah. Sometimes I see organizations, especially if they don't have a lot of incident reports, even a cancellation on a day of surgery might show up as an incident report. So it's really up to you to define what, how far you want to go down with identification of these incidents. And I find many organizations that do a small number of cases will actually be, quite aggressive in trying to find incidents.
Always trying to improve.
Right.
And that's fine. And it is important to note, and it's kind of what you were saying, but the definition of incidents as opposed to adverse events doesn't necessarily include any patient harm, not just not involving the patient, but if there's something done a little bit differently, but nobody got hurt, you can't just say, well, thank goodness it was a near miss. No, if something was done wrong or differently than you had planned to do it or should have done it, then whether there was harm or not, it's considered an incident. And that's the way you hopefully avoid having patient harm in the future.
Right. And one thing I always talk about when we do training on quality improvement programs is that you have to understand when you're doing incident reporting that this is not a hospital. ASCs are not hospitals. And many doctors, when they come to a surgery center, they really are very resistant to any incident reports at all. And that's because they're used to the hospital attitude, which tends to be much more aggressive and much more, it gives the doctors the feeling that somebody's going after them. You also have to remember that this is protected information. In other words, this information cannot be subject to disclosure unless you don't do a good job of protecting that information, but it can't be subpoenaed during a lawsuit. And it's also important that you understand that this is extremely important. As I mentioned before, this is the heart and soul, I think, of the quality improvement program.
And getting the doctor or the nurse or whoever else was involved in it in a gentle discussion about it of, what do they think could have been done differently? Was there some systemic error that, that made it easier for human error to take place? And just, I think once people go through that type of a process a couple of times, they're much more willing to talk about it if they see that you're going to take their input and that you're really just trying to protect everybody.
Right. I think one example that I can give to demonstrates what I expect to see in an incident report is, let's say you transfer a patient to the hospital for pain control. They have unrelieved pain, and they have to go to the hospital for whatever reason. I don't want to just see the incident report saying the patient went to the hospital, they were admitted to the hospital for 2 days, and they were discharged with having fully recovered. I want you to investigate, is there something you could have done to not have that patient experience that level of pain? Was the transfer performed properly? Did you call the ambulance at the right time? Did you call them too soon? Did you call them too late? How did people respond to the emergency?
Is it possible you missed something on pre-op? Do they take some type of pain medication or opioid on a regular basis, so the pain meds didn't work as well? Yeah,
actually, you bring up a very good point. That actually, I was at a center a couple of weeks ago where a patient was in extreme pain, and one of the things that I believe they found out during this is that he had taken some marijuana during the day and had not reported that to the doctor, and the doctor feels that might have been a contributing factor. And all of that should be written up as part of the incident report and a lesson to be learned. Yeah. And I think one of the biggest issues or one of the biggest outcomes from this was that patient an appropriate candidate for surgery at the center? Because we're always looking to make sure that only the right types of patients are brought to the place. And I also have to say that this is what you do every day. I know I'm talking to nurses. I'm sitting right next to a nurse here in the studio. You're doing this all the time as part of your regular job. You're identifying problems. You're fixing them. What we're talking about in incident reporting is now you're documenting that process so that you can learn from it and make sure it doesn't happen again. And you also have to remember that quality improvement has to be a safe place. There should be it's non-judgmental. We're trying to find the solution. As Sue, you mentioned earlier, is it a systemic problem? Is it not related to one individual? Is it something that is systemic in nature, and therefore the organization itself has to address that problem? And as I've said before, and I'm going to say it another way, a culture of safety in your organization starts with good incident reporting. I did want to mention when you're reporting in your quality improvement minutes, here's a recommendation. You break down your incidents into several different categories. For example, the first one should be adverse events or sentinel events, depending upon your accreditation organization. Next, state reportable. There are many states that actually state specific types of incidents that have to be reported to them, and you're going to want to include that in your quality improvement minutes. OSHA and safety issues such as OSHA breaches or any safety incidents that might have occurred in your organization. And many of these would actually involve employees. And then other incidents or occurrences such as non-adverse events and non-patient events. And of course, make sure that you're closing the loop on these also. Near misses and their resolution. Grievances are usually documented as part of your incident reporting process. Written complaints or validated grievances is what we're talking about here. And cancellations. Now, I don't always include cancellations as an incident because many organizations have many cancellations. But if you have very few cancellations, you might want to track this as an incident. And of course, hospital transfers are, always an incident. I guess that was a conversation I had with one center a while ago. They didn't realize that all hospital transfers even those that, where the patient was transferred to the hospital even before the patient was treated. In other words, they identified like a cardiac problem in pre-op. Even those have to have an incident report done.
And look at, is it something you missed on the pre-op? It may not be. It might just be something that happened, and thank God they were with you and you found it.
Right.
And for cancellations, it's generally just day of service, right? Because that's where you lose the money and you slow down your operations.
Right. And then I want to make sure that also as part of your quality improvement minutes that you track and trend those incidents. In other words, show like quarterly statistics as to how many of each type of incident you have. That is a requirement of the accreditation organizations to do these tracking or trending. Another term for tracking and trending is internal benchmarking. So once an incident is reported, the next step is processing and investigating it. CMS interpreted guidelines emphasize that ASCs must analyze incidents to identify root causes and prevent recurrence. And this aligns with the accreditation organizations. Now, some situations may require you to do a root cause analysis, which is a very formal process for investigation. But I would say the vast majority of incidents don't actually have to have a root cause analysis. Of course, you want to assign responsibility, and this should be in your policies. So you want to designate some qualified professional, usually your QAPI coordinator or infection control officer, to lead the investigation. And then you want to gather any data that you have, from the medical records, reviewing the medical records, interviewing the staff, and reviewing the policies and education of all the staff. And as I said, a root cause analysis would be used for much more complicated situations where you've identified significant issues such as communication breakdowns or inadequate training. And CMS and accreditation bodies really expect timely investigations, typically within 30 days, depending upon the severity. Sometimes you might need to have an emergency QAPI meeting if the issue is serious enough to warrant. And lastly, of course, we want to make sure that we are truly identifying opportunities for improvement, as we've just discussed. Investigating these incidents is not enough. ASCs must identify opportunities for improvement. And this is actually directly out of 416.43. which requires QAPI programs to implement corrective actions based on data analysis. And you want to develop in this situation action plans, for example, that would address the root causes with specific measurable interventions, such as staff training or policy updates. And you have to monitor its effectiveness. You want to track the outcomes to ensure those interventions work. And you want to engage staff. Involve the frontline staff in brainstorming solutions to foster a culture of safety.
And that's basically, you're kind of doing a QI study there.
That's correct. Yeah, especially QI studies are often come about as a result of some type of incident reports that you might have generated, especially when you start to see trends. Finally, ASCs must report incident outcomes to the QAPI committee and the governing body. And 416.41 of the CMS Conditions for Coverage mandates that the governing body has oversight of the QAPI program, ensuring that its policies provide safe care. So the QAPI committee will review the incident data, investigate the findings and action plans in their quarterly meetings. And then the governing body will get summarized reports, including trends and improvement outcomes, at least quarterly. And I do want to stress that to have a good organization that meets the conditions for coverage and interpretive guidelines, as well as the accreditation standards, your governing body and your quality improvement meetings have to occur at least quarterly so that you can address things on a timely basis. So that wraps up our focus segment on incident report preparation and processing. By following the CMS conditions for coverage and the accreditation standards from your accrediting organizations, you can assure robust incident management that enhances patient safety and quality care. So some key takeaways, of course: document incidents thoroughly, investigate promptly, implement data-driven improvements, and maintain clear communication with QAPI and the governing body. For more resources, you might want to consider some of our bootcamps at ASC-Central.com. Let's take a short break, and when we come back, we're going to talk about upcoming events.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So, of course, as we've mentioned several times during this podcast, ASCA 2025, the ASCA 2025 Conference and Expo is April 30th through May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado.
And the Gulf States Conference is June 11th through the 13th, 2025 at the Ritz-Carlton, New Orleans.
And that includes Alabama, Louisiana, and Mississippi ASC associations. And the Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 23rd through the 25th, 2025 at the Hilton Orlando.
And the New York State ASC Association's conference will be held October 6th through the 8th at the Desmond in Albany, New York. And John will be speaking at that conference. And we'll be doing a special episode there, and a whole group of us will be there.
Yeah, we'll have over 12, 13 people there. And the Oregon ASC Association's annual conference will be October 9th and 10th, 2025. More information is going to follow. I believe, Sue, you indicated that they still don't have this on their website, right?
I guess, but we know it's then because you're speaking, and we've been in communication, so.
Yeah, so I'll be speaking at the conference, and we have been asked to do a special episode there. So more information to come, and we'll keep you up to date.
And the Joint Commission's Ambulatory Care Conference is November 5th through the 6th, 2025 at the Crowne Plaza, Chicago O'Hare in Rosemont, Illinois.
And the Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th, 2025 at the Tulalip Resort and Spa in Tulalip, Washington. And I'll be speaking at the conference. I think it's 3 sessions there, and we will do a special episode from there also.
And the Colorado ASC Association's conference will be held November 13th and 14th at the Denver Marriott West in Golden, Colorado. And John will be speaking, and we'll plan to do a special episode.
And this is in Golden, Colorado, where I believe that Golden Retrievers have an annual event there. So, unfortunately, I guess I won't be there during that event.
I don't think we'll be flying, Rosie there, no.
So, on-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers bootcamps are available on our sister website at ASC-Central.com. And you can follow a link in our show notes. And a reminder to everyone to become a patron member of the podcast. Don't miss out on the benefits of joining our patron member program available at ASC-Central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. And it's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. At the present time, I think we have over 300 patron members of the podcast. By becoming a member, you gain access to regular Zoom sessions, typically held weekly, where you can engage with other patrons and our podcast team. But that's just the beginning. Your membership unlocks a wide range of resources, including access to some of our virtual conferences, such as the Credentialing Conference and the Conditions for Coverage Conference. And you also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support of the Patron Program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Please reach out at any time at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here at the podcast, our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ASCPodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.